well, let me see here. So, I got the. Do you have MRI results or the picture or something?
No, I can't really pull it up here very well, but I've looked at them and.
There's like 5 things on it.
Yeah, I'm gonna. Actually, why don't I start with that? So, what your MRI scan shows to me is it shows your ACL is torn.
Uh-huh.
It shows you have a tear of your lateral meniscus, which is on the sides.
Partial.
And you have a bone bruise, which they're in a pattern that goes with an ACL tear, but are not something that requires independent intervention. I think your collateral ligaments are okay. The radiologist, so the way an MRI scan works is if something is stone cold normal, it's a ligament is stone cold normal, it's black. And if there's a little gray in it, they say, oh, it's partially torn. But they never see patients to know what's going on. And the way you can really tell if a ligament is torn is
by doing a
well, is it working or not? So the ones on the sides, so your lateral collateral ligament is this one over here. And the way I would check that is I'd have you do a figure 4. I don't know if you can do that very well right now. Kind of go like this. Think you can?
Almost.
Here, here now. Perfect. I'll think about doing that. And if in that position, I can put my finger right here, and that hard thing that's like a pencil under my thumb, that's your lateral collateral ligament. So you can feel it, you can test it, it's solid, it's okay.
So 3 out of 4 are okay?
And then the one on this side is your medial collateral ligament. You can test it, it's solid, it's okay. So 3 out of 4.
Okay, so
it's
better
really,
news.
it's really your ACL and your meniscus. That's
what's meniscus?
So your meniscus is this little shock absorber thing between the 2 bones.
So is it like a cartilage thing or what?
It's like a fibrous thing. So it's like a fibrous spacer here. And you have a tear of it in the back on this one. And that goes commonly again with an ACL injury.
So this one is ripped and the stuff between the bones?
Yeah, on this one side.
So is this prevents arthritis? Is that what it is?
That's right, yeah. So if you lose the function of your meniscus, you have an increased chance of arthritis. And that part is actually more of a risk of arthritis in the future than the ACL is. But they kind of go together because if you don't have an ACL, then the next thing that tears is your meniscus.
Okay. And then the fluid or something was number 5?
Well, yeah, of course, when you're hurt, you have fluid in the joint, right? If you sprain your ankle, you have fluid in your ankle.
Never. This is the first time that pretty much I did something.
Oh, okay. Yeah.
So
well, if you have a bruise, it swells, so yeah, that's what fluid is. Yeah. Yeah.
So again, that one's for sure totally out?
The ACL? Yeah. And you can tell from the scan. You can also tell because the bone bruises, that pattern wouldn't happen if you had an ACL that was okay. And you can tell when Mike
because I can't bend it.
When Mike has your leg here and he does this, you can see that moves further than normal. So all those tell us your ACL is torn.
Does it so is it attached but just do you know which
really
part?
Not attached, yeah. The ACL.
No, I'm talking about like which is it like is it in the middle or do you know where it's torn?
Well, I would say we don't really know, but it doesn't matter.
It doesn't matter. And it doesn't heal.
Right. The ACL doesn't really heal together. What happens is it's kind of like a rope hanging from the ceiling. When it tears, it falls to the floor.
So
it's not going to climb back up and heal there. Yeah.
Okay. And so you're saying these are okay, 5 points. So I guess like with the physical therapy and stuff, and having 3 of them still functioning, you can probably live.
Okay.
Not play basketball, no.
Yeah. Okay. Well, let me go through that part for that. So when you tear what your ACL does is it keeps your shin bone from sliding forward on the end of your thigh bone, and you kind of don't need an ACL to just walk around. So if you didn't have the ACL fixed, okay.
So my weapon.
If you didn't have the ACL fixed, you should be able to get back to where you can walk around and go to the gym and ride a bike and lift weights and things.
So I can ride a bike?
But you probably couldn't get back to doing things like basketball or soccer or skiing, that kind of thing, where things happen faster or harder than your muscles can handle on their own.
Uh-huh.
And if you try to do those things and your knee gives out because you don't have the ACL, well, then you'll hurt the next things in your knee. So, like your meniscus, for example, which is torn already.
Well, speaking of that, meniscus. So you say it's torn.
It's torn, and it looks like a piece of it is probably sticking out in the front, and that's probably why you're having a hard time getting your knee to go straight.
Meaning, it's like piece of it is.
Yeah, yeah. So if we try to straighten out your knee here, you can see it kind of goes to about there, and then it kind of doesn't want to go further. Actually, you're doing it pretty well.
Yeah,
so there's a piece of.
Yeah. Where are you going? I mean.
Yeah. So there's a piece of it that's sticking out. So what I would tell you is, independent of the ACL problem, the meniscus usually hurts and causes you trouble until you get something done about that too.
So, going back to that example, this whole thing is sticking out like that or something?
No, part of this is torn in the back, and there's a piece of it that looks like it's kind of flipped over like this, where it's getting caught. But we're just talking about a smaller piece of it.
Oh, like flipped or something?
Yes. Yeah. But the bottom line is, a tear of the meniscus, it's a little bit like having a rock in your shoe. You know, you're stepping on it and it bothers you and it hurts and it makes your knee swell. So you have that problem. And then you also have the ACL that's torn, separate problem. So if we did not do surgery, the ACL won't heal, but if you were very careful about what you did, you might be okay. But the meniscus would still bother you in your case because you've got two things.
So, how do they fix meniscus?
So what we would do is, with the meniscus, you go inside and you look at the meniscus, and if you can put the piece back in place and sew it together and save it, that's the best. If you get in there and the piece is just all torn and shredded into pieces, you take out that torn piece so that it won't get caught between the bones anymore.
And so there's no cushion anymore?
So then you lose that part of it, yes.
And then you have bone on bone then after that?
Well, no, you still have the slippery white layer on the end of the bone, you know, the white layer on the end of a chicken bone, for example. You still have that, and that's what the cartilage is. So
and there was something about cartilage too, on the MRI, I think, one of the numbers.
Yeah, I think your cartilage is looking okay. But at some level, it doesn't really, again, it sort of doesn't matter because you have what you have. You know, if you do have an injury to your cartilage or your meniscus, then you have one and you deal with it when you see it there. It's not like there's a different thing to do.
So the two main things is right now is the ACL's gone and the meniscus or whatever it's called.
Yeah. So those are the two things of significance, meaning the two things that we can do something about, and also the two things that I would expect to give you trouble if we didn't do something about.
And the meniscus, you said it's like a rock or something issue, bothers later on?
Right. Yeah, so it's a fibrous thing that gets caught between the bones if you have a tear and it hurts.
So I guess for the surgery, they go in and do it all in one shot, if that's the case?
Yeah, so when you have so the ACL part is the biggest part of the surgery. So that takes about an hour to do. And what you do is you look inside the knee through several small holes with a scope. And you take out the remnant of the old ACL that's not working anymore. And you make a new one using a piece of tendon from you. And I use a piece of the one that comes down from the kneecap here. So we make an incision about this big to get a strip of tendon, and then we basically put it across the knee where the ACL is supposed to be. So well, let me get there.
Uh-huh.
So we put it across the knee where the ACL is supposed to be, and we hold it in place at each end with a screw, and that's what makes the new ACL. That takes about an hour, and at the same time, we would look at the meniscus, and depending on what it looks like, we would sew it together if we could, and we take out the piece that's not helping you anymore, that's broken, we couldn't sew it together. And the whole surgery is usually just a little bit more than an hour. We do it as an outpatient at the surgery center that's right here across the parking lot. Usually you're there for 3 to 4 hours total. You go home then that same day. Usually you're using crutches and a brace for about 2 weeks. We have you work with the physical therapist starting about 5 days after the surgery to help you get the knee going again and to help you know what to do next. Usually by week 3, you're walking around reasonably well day to day. You're not using the crutches or the brace or anything anymore. And then we have you keep on working with the therapists and increasing your activities and working on getting things going again. And the goal is it takes about 6 months to get back to where you're doing running, cutting, jumping things. But you should be working out at the gym starting at 1 month, just doing exercises that are okay to do.
No basketball?
Probably not for about 6 months for basketball.
So pretty much this summer is over.
Yeah, for basketball I would say so, yeah.
And then you said no surgery, no basketball for the rest of the life? Pretty much? Unless you want to hurt other things?
Exactly. I think you would probably have your knee give out and you would not only not be able to play because your knee gave out, but you would probably damage other things in the knee.
And then for the surgery, is it Kaiser that's doing it? Because I'm a little bit confused.
No, I would do it here. So you have a Kaiser insurance, but we could do it here. So we have a contract with them where they send people out or sometimes let people out if they have a backlog. And then.
So you're the one who's going to be actually doing it?
So I would do it, yeah.
How long have you been doing it?
Since '97.
Okay. Do you get a lot of patients?
I do about 50 a year.
50 a year?
50 a year of this, yeah.
And what's the good case and what's the bad case, I guess?
So what are the risks of the surgery? Well, the first one is anytime one makes a cut in the skin, you can get an infection. The chance of that is about 1%. If you have it,
staph infection
you
or
might
something?
need another surgery to wash out things, and you'd be on IV antibiotics for a while to have it go away. But you probably wouldn't have to have the surgery done again. The next risk is the chance of a blood clot.
Yeah, I got it down here.
And that's probably about 0.5%. And then the next risk...
do like that or something, people tell me.
Yep, that helps. The next risk is the chance of tearing the ACL again. And for me, for the last 5 years, that's been 2% that have torn it again. And usually back doing sports and things like that.
So the new one that's put in there?
So you can tear that one again. Then there's 3 things that I want to make sure you have heard about because most people have those. So the first one is when you have a cut in the front of the knee, it's numb next to it. So you don't have normal sensation because you've had an incision right there. And it
like for the rest of your life?
And it bothers you when you kneel on something, especially something hard. So I've had a knee surgery, and I would not like to kneel on this. But the carpet outside, even though it's very thin, that would be fine. But I wouldn't like to kneel on this. So if you have to, if you have a job where you're kneeling all the time, you kind of get used to it. But it never gets to where it's feeling.
So you lose the part right here, the numbness becomes numb?
Maybe only about this big, but it's right where you kneel on. Then the next one is, anytime you have an injury to the knee, if you move the knee around, it makes noises like that. It makes kind of crunching, grinding noises. Everybody gets those as they get older.
You had ACL too?
I didn't have an ACL, I had a different one. But everybody gets noises as they get older anyway, but you get them after surgery. And then the third one is that anytime you've had an injury to the knee, the muscles really get very thin and soft, and it takes a long time to get them back. So during the time your muscles aren't very good, your knee doesn't feel very good. And that's the big focus of the rehab.
So you said that the times, I know a guy who had the ACL done and they had to redo it 5 times for whatever reason. The ACL, he took it from like a dead person or something, and it didn't work out or something.
Yeah,
and and then he had an infection or something, and it's like the whole deal was like 5 times. I'm like, ouch.
Well, that would be unusual. I don't like to use the donor grafts, the one you say from a dead person, because they're much more likely to tear again than the ones from you.
My other friend, a person I know, she just had a surgery, and then they took, instead of taking it here, they took it from a ham, something from here.
Hamstring, yeah.
So is that a different option?
That's an alternative. And what I would say is, if you do the hamstring, you have less numbness in the front of the knee, but it's more likely to tear again than if you do the other one. So this one is more stronger?
So
the patella tears again maybe 2% of the time.
But patella means this?
Mm-hmm. The hamstring tears again maybe 8% of the time. But the hamstring probably is a little less uncomfortable during the rehab.
So it's easier now, but in a long time there's more chances of ripping it?
I think that's a good way to say it, yeah.
And so do people get a preference or something, or how? Or you just usually take
I usually just do the patellar tendon one, because I believe the worst thing that would happen is that you'd have to have the surgery again, rather than that it's uncomfortable to kneel on it. So if someone comes in and they have a job laying flooring or something like that, we discuss it some more. But otherwise, I just do the patellar tendon one.
How long it takes? So you said you already talked to recovery. You said 3 weeks?
Well, what kind of work do you do?
Office.
Okay. So I would say the first week, I would definitely take the first week off. The second week, you'll probably still be walking with your crutches and things a little bit, but I think you could probably go back.
After the surgery?
Mm-hmm.
And no surgery. Some of the stuff already talked. I don't want to write it down. And then the physical therapy, you said 2 weeks or 3 weeks later?
Nope, starts 5 days.
5 days.
So that first week you see the therapist already. So if we do the surgery on a Thursday, I'd like you to see the therapist on, say, a Monday or Tuesday.
Wow. And then...
And where do you live? Close to here?
Beaverton.
Okay, so I'd probably set you up to come here for the therapy too.
I guess if for the examples you were saying 2%, 8%, so people would come in and you'd have to like redo because it tore again, so we'll have to do it again, like
sometimes
few cases.
Sometimes, yeah.
And what, do you drill a new hole or something, or?
If you had to, yeah, you drill a new hole, and then if they had the hamstring, you do a patellar tendon. If they had the patellar tendon, you do a hamstring.
Different thing. And then I just read a few stuff on online. They said if you drill like wrong angle or something of the hole, then you can't bend your knee, and if it rips and stuff.
Yep.
Stuff like that.
Put them in the right place for it to function the way it's supposed to.
So like, what are we looking at here for the knee? I guess you said about this much or something.
The incision's probably about this long, and it's probably
under 2 inches.
It's right about like that, Yeah, under 2 inches, about like that. And then there's a bunch of little small holes where you look in with a scope and things.
And so there's gonna be like a hole in this bone and a hole in this bone and the screws. Is it like titanium or something? Or
They are titanium, yes, they are.
kind of like implants?
Sort of, yep. Similar idea.
So I'm not gonna be ringing at the airports.
I don't. I have 2 screws in my knee and they don't. So.
And the question right now, I guess, is for the surgery not to do it, let's say now, but in the future. Is that a possibility?
Yeah. As long as you're not doing things where the knee might give out, as far as the ACL goes, you could wait as long as you want. But the meniscus, that one may well bother you until you have the surgery for it.
So no, I'm saying like, if let's say a year later or something, I'm like, I don't want to do it now, and then half a year later or a year later or a month later, I'm like, okay, let's do it or something.
We could do that. We could do that.
That's an option?
That's an option.
Okay. Pretty much most of the stuff we talked about. Oh, for the surgery, you guys do general anesthesia or it's?
Yes.
Well, I think there's like a general is when they breathe for you to put a tube in. So with the tube.
Yep. So you have a general anesthesia. So it's not with a tube that goes down your throat. It's a different technique, but it is an anesthetic where you're asleep.
Okay. Okay. So you're no tube though, right?
Right.
You're not. Okay, because the tube one is like general anesthesia with the tube. That one is okay. I think there was a different name for it, but.
So.
And then you have to like lay for like a week or something with elevated.
The first week you're mostly letting things settle down, but you start physical therapy 5 days or so.
How do people get up, like shower in the restroom and stuff?
You get up and you
Jump.
walk with your crutches.
So you can, it's gonna be like straight or something?
Right.
It would have some equipment on it or something?
Yep, you'll have a brace and crutches, yeah.
And how much is it, I guess, would be?
It would be the same as, with Kaiser, I think it's just the copays that you would make. So
Do you know what the copay is now?
I
No
don't.
idea?
I don't know the answer to that. The way that we would usually figure that out is we go ahead and schedule it, because then they know what we're wanting to do.
Mm-hmm.
And then you would ask the people in the billing office, and they can help you with that.
Here?
Yeah.
Okay. So I'm still a bit confused with you and Kaiser, I guess. They just send people here sometimes, and then you're kind of on your own doing your surgery.
So
and then they have their own surgery place also, or something.
They do. They have their own surgery place too.
Mm-hmm.
And if you can come here directly,
Mm-hmm.
or sometimes they will send people here because they have too many patients, and it's 2 months before they could do the surgery or something like that.
Mm-hmm.
So then they'll send some people out to see us
Mm-hmm.
to do it instead.
Well, that's why I came here, because they're like, oh, we're 2 weeks out for talking about the MRI and stuff. I'm like,
Oh,
okay. Anything sooner? They're like, well, you can go to Portland Clinic. I'm like, huh, what? Really? So that's how I got here. I think that's pretty much all.
Okay. Well, so what I would suggest that so first, if you would like to say I want to think about it some more, that's okay, of course.
Yeah.
Otherwise,
I'm gonna talk to my wife.
what I would do is I would put in the stuff to get you on the schedule.
Uh-huh.
And then that way you could also call and talk to the billing office people, because they'd know what procedure we're talking about doing.
Uh-huh.
And then after that, it would just be a scheduling question. I usually do surgery on Thursdays.
Oh, really?
So we'd probably be, I don't think we could do it next week, it would probably be the week after. But it's just, again, it just depends on what.
So
is on the schedule.
it can go as soon as in 2 weeks on Thursday?
Mm-hmm. I would think so, yeah.
And so you put like, how many people do you usually do a day? So just one day, and the rest of you are just kind of here?
Right, I just have one surgery.
And this across the next building there?
Yes.
think that's pretty much it.
Okay. Well, what I'll suggest, just because it's easier for me to do it this way, why don't I put in the stuff to put you on the schedule?
Mm-hmm.
And then when you can talk to Erin, she's our surgery scheduler person, and when she says, when do you want to do it? I would say, I'm kind of thinking about doing it in 2 weeks, but I want to talk to the billing people first so that I make sure I understand how much am I going to have to pay.
Mm-hmm.
And then you can do that, and if everything's good, we're on the schedule for 2 weeks or whatever done. And if there's a problem, you can always cancel it if you want to, if you know the money's something different than you expect or whatever. Does that sound okay?
So you put it in just now, and then, or should I just call in later? Let's say after I talk to my wife and kind of figure out what we want to do.
For me, it's easier to put it in now and cancel it if you change your mind than it is to have you call and then go through everything then.
Okay.
So I'll suggest that I put it in now, and we pretend you've decided. But I understand that that you can change your mind. It's not a big deal. It's just logistically easier to do.
Okay.
When you have everything in front of you now.
Okay.